seats. That corner, people, students sitting in that corner. Get up quickly. Please don't delay. Please get up quickly without any delay. The fourth row is vacant on this side. It's vacant. कोई बात नहीं, आगे की सीट्स खाली हैं. Come to the front seats. Come quickly. Okay, so we had discussed about the various vitamins in the last lecture, and now we'll be discussing about the common nutrition problems in the community. It's silence, please. No further talking. No talking, please, or I'll have to send you outside. Arjun, sit at the back. See that they are not busy with their mobiles and other things, and ask them to settle down fast. Okay, so the common nutrition problems. क्या प्रॉब्लम है? बैग ये सामने किसने रख रखा है इतना बड़ा? क्या दिखेगा उसके थ्रू? You've got X-ray eyes. Please keep your bags on the ground. क्या हुआ भाई? बैठने में टाइम लग रहा है? कब तक खड़े रहोगे? खड़े होके अटेंड करना. You can stand and attend the class. It's not an issue. Get in quickly. Close the door. Close it. Okay, so the common nutritional problems that we encounter within the country are the low birth weight, which is the commonest, and then we have protein energy malnutrition. So all these are nutritional disorders. Xerophthalmia we have already discussed. You remember it? What was xerophthalmia? Okay, and then you have anemia. So it's not, xerophthalmia is not dryness of eye, it is vitamin A deficiency, ocular signs and symptoms. A combination of ocular signs and symptoms which occur due to vitamin A deficiency is known as the term xerophthalmia. Okay, conjunctival xerosis is dry eye, and then you have other signs and symptoms also which come up gradually. Okay, so you have xerophthalmia, then you have nutritional anemia and iodine deficiency disorders, endemic fluorosis and laterism. So amongst these, xerophthalmia we have discussed. Low birth weight will be discussed in detail during your 5th semester classes, I guess, when we talk about maternal and child health. So there we'll discuss it in detail. Nutritional anemia, iodine deficiency disorders, endemic fluorosis and laterism will be discussing simultaneously. Okay, so subsequently, sorry. So in the next few lectures, these topics will be discussed. Today we'll be talking about the protein energy malnutrition. Okay, so these are the learning objectives of today's class. So we understand the concept of PEM, what are the factors associated with it, how to classify it, and then what measures should be taken for prevention and treatment of PEM. No talking, please. Okay. So malnutrition is something which is deviating from the normal nutritional status. Okay, so it will encompass the protein energy malnutrition, it will encompass the micronutrient deficiency also, and it will also include overnutrition. Okay, so that is obesity and overweight. So all three are a part of, are classified as malnutrition. Okay, so malnutrition will have all three components. So anyone who is suffering from either of these conditions will be classified as being malnourished. Okay, So you can see that there's problem of underweight, stunting, wasting. So underweight is said when a person is underweight for one's age, that is weight for age we take. Stunting is when a person is too short for one's age. So there is a variation, but then within that variation also, if someone is too short for that age, he is stunted. Then there is wasting, which is weight for height. So for a particular height, a person should be of particular weight. So if a person is out of that range, so then he or she is wasted. Okay. And then we have micronutrient malnutrition, which we have discussed while we were discussing vitamins and mineral deficiency. We'll be discussing subsequently. So vitamin deficiency, we have discussed various micronutrient deficiencies. We have discussed about the beriberi and other signs and symptoms that we saw. Then we have double burden of malnutrition, which is now upcoming. क्या बातें हो रही भैया? क्या चल रहा है? मतलब पार्क में बैठे हो? पार्क है ये? आ जाओ, उठ जाओ. Get up. Get up. Don't force me to take actions, okay? पार्क में बैठे हो, ये पार्क चल रहा है, क्लास है कि पार्क है? क्लास है ना, तो क्लास के डेमेनर को मेंटेन करना चाहिए नहीं करना चाहिए? गप्पे मार रहे हो आराम से, कुछ और पैरेलल बातें चल रही हैं, पूरा दिन पड़ा है उसके लिए. सैटरडे आज हाफ डे है. आफ्टर दैट यू कैन डू व्हाटएवर यू फील लाइक. ओके. No such indiscipline I'll tolerate in the class. You're sitting in the class, please focus with the class. You don't want to attend the class, please leave the class. Don't create disturbances. Okay, so malnutrition is a range of conditions which occurring when intake of one or more nutrient does not meet the requirement. Either it exceeds the requirement or it is under the requirement that we require. And protein energy malnutrition is one of the very important nutritional problems, especially in the preschool age children, that is less than 6 years of age. So that is a very common age where protein energy malnutrition happens, and that will also lead to reduced, it has been found to be a factor which has led to overnutrition in adults. So someone who was undernourished in childhood, we have found that there is a phenomenon of double burden of malnutrition, which says that these are the people who tend to get obese later on. Okay, these are the people who also will tend to get they'll be malnourished maybe for the rest of their life. So both things can happen due to undernutrition during childhood. So the main cause is food inadequacy, but then behind that food inadequacy there are a lot of factors which play the role. Okay, so food inadequacy is one of the important, like it's the connecting link. But then behind that, there are a lot of other factors also which we'll discuss subsequently. Then earlier it was attributed to the protein gap, but then it's not just protein, so that is why it was named as protein energy malnutrition. But it's the energy and protein in varying combinations which causes the manifestation of this particular condition. So food gap is the chief cause, and it is not only the deficiency of proteins but inappropriate food that is low in energy density, protein as well as micronutrients. So whenever there will be a protein and energy deficiency, there is going to be a micronutrient deficiency. It will come along. Okay, it does not happen independently. Because a protein deficiency ho gaya because food intake is inadequate. So simultaneously the child will be having other micronutrient deficiencies also, and that is why when we treat protein energy malnutrition, we do not just treat for protein and energy deficits, we'll also take care of other things. Okay, so it occurs both quantitatively also, and it will occur both qualitatively. So there are quantitative in terms of quantity it is less, and also the quality it is less. So good proteins it's not there. Okay, so absorption is not proper and all those things happen. The WHO defines it as a range of pathological conditions arising from coincidental lack in varying proportions of protein and calories, occurring most commonly in infants and young children, and which is commonly associated with infections. Okay, so that is how WHO defines it. The definition is kind of comprehensive, So it is a coincidental lack, means both things are lacking, and commonly it occurs in young infants and young children. Infants, you know. Who are infants? Infants are? What's the definition of infants? Children less than 1 year of age. Okay? So children who are less than 1 year of age are termed as infants, and beyond that it is young children. Okay? And this deficiency will be associated with infections commonly. Okay? Magnitude, if we see, it's more than 1/3 of the world's population. We have protein energy malnutrition, and for all indicators of PM, a total of 80% of children affected live in Asia. Okay? And we are an Asian country, Southeast Asian country, mainly Southeast Asian country. So 80% of all who are malnourished all children who are malnourished are found in Asian countries. And 43% of children in developing countries are stunted. 50% of child deaths in developing countries are related to malnutrition. So malnutrition is kind of a underlying cause for most of the deaths. So malnutrition होगा underlying cause, उसके ऊपर infection होगा, और infection के कारण the child will die. Okay? So it is an underlying cause of death in 50% of child deaths. Okay? So had it not been there, 50% of the child deaths would have been saved. That is what we mean by it. Okay? So this is the report of NFHS 5, okay, which was conducted recently. So National Family Health Survey 2019-2021, and these figures in the last column are of NFHS 4, which was done previously. So if you compare the figures now, so urban, rural and total prevalence percentage is given. So we can see that percentage of children who are breastfed within 1 hour of age, it should be ideally all children should be breastfed within 1 hour of birth. Okay, so within 1 hour of birth, everyone should get a breastfeed, but that percentage is very less, just 44%, 40%, 41% on total. Similarly, exclusively breastfed, it's 60% total. More in rural, less in urban, strikingly. Then those who are stunted, that is height for age is less, is 35%. So prevalence is 35% of the children are actually stunted. Then those who are wasted is 19%, and those who are severely wasted is 7.7%. Okay. Similarly, if you see underweight, it is 32.1%, and then overweight is also coming up now. So we have children under 5 years of age who are overweight. Okay, so the weight for height is more than what it should be, and that percentage is going up. In urban 4.2%, and in total it is 3.4%. Even in rural we can find it is 3.2%. Okay, so this is gradually catching up. Previously it was 2.1, it has almost डेढ़ गुना हो गया है. So if we see that way, so if it goes by that same rate, by the next 2-3 years we'll see another, maybe it's 10% or so. So that is something that we are now facing. So it is double burden of malnutrition that we are now struggling with. Okay. Okay. So the determinants, if we see, so determinants are basically broadly classified under 4 distinct categories. So there are environmental factors which are there, which include the physical and social environment. Then we have behavioral factors also. Then we have healthcare service related factors, and we have biological factors. Okay. So this is a basic health field model which has been proposed by Lalonde, and which says that the health is determined by these four factors. Okay. So health of an individual is not an individual thing. It is determined by lot of things which are there, and that is why health को improve करने के लिए जब हमें action लेना होता है, so it is not unidirectional. It is multidirectional and multitudinal. Okay. So we have to take actions at different aspects of the health so that we can improve the health. Okay. So environmental factors, if you see, there are many environmental factors. So if a child is malnourished, so there are a lot of factors. The most important is the socio-cultural factor that the child is in. Okay. Social cultural factors will determine what? उठाओ उसको आगे, तुम्हारे जस्ट बैठा हुआ है. Stand up. Stand up, stand up. Stand up. Keep standing. Okay? The socio-cultural factors, they affect feeding practices and they will determine. So each family has their own socio-cultural factors, each community has its own socio-cultural factors, and that determines how much delay is going to be there in initiation of breastfeeding. So there will be elders in the family will say no, अभी नहीं दूध पिलाना शुरू करना है, पहले तो उसको शहद चटा दो, प्री-लैक्टियल फीड्स का है, फिर उसके बाद नहीं अभी तो इट्स नॉट, कुछ और खिलाना है, कुछ देयर सम पूजा और वेरियस प्रैक्टिसेस आते हैं. ओके, देन लैक ऑफ कोलोस्ट्रम, नहीं पहला दूध जो है, जो पहला गाढ़ा दूध होता है विच इज कंसिडर्ड टू बी प्रोटेक्टिव, generally in lot of families it is discarded. Okay, considering that it is, because it's not milk like, milk is white in color, no, but colostrum is not milk like. Okay, so that is actually discarded because it's not milk like, thinking that it's not good for the child, while it is the most beneficial thing that we can give to the child. Okay, गाय का जो पहला दूध होता है, शुरू का जो दूध होता है, that is we consume it very like this कि हाँ अरे वाह, गाय जब बछड़ा देती है तो उसका दूध कंज्यूम करते हैं ना हम लोग सारे, and we make delicacies out of it also. But human milk generally it is discarded because of again social cultural जो हमारे factors हैं. Also inappropriate complementary feeding होता है. It's been found that the duration of breastfeeding is also not exclusive. 6 months तक का exclusive breastfeeding नहीं होता है, which is described. So the boys might be breastfed exclusively for a longer period of time. The girls are breastfed for a lesser period of time. So all the socio-cultural factors play a lot of role in determining what is the breastfeeding practices. Okay, so that leads to a gender difference. So girls are more malnourished. Under 5 girls are more malnourished as compared to the boys because of these differential practices also. Also, mother's literacy status is a very important factor. So the more educated the mother is, the lower the rates of malnutrition would be. Okay? Jitna zyada educated, Arjun, just take a round and see they are not busy with other things. The lecture is not for you. Yeah. You wanting to listen to the lecture? Yeah. Okay, just keep taking a round. You just need to move around. Yeah. So, mothers taking a round does not mean you sit from there to there. भाई कमर जरा सीधी करो, अपने पैरों पे खड़े हो, थोड़ा साइड होके खड़े हो जाओ और साइड हो जाओ, निकल जाओ चेयर टेबल के सपोर्ट सिस्टम के बाहर. पैरों पे खड़े नहीं हो पा रहे हो, क्या एज है? हाँ, चोट लगी हुई है. कहाँ चोट लगी है? दिखाओ जरा आके, देखो जरा इनकी चोट एग्जामिन करो. अर्जुन, इनकी चोट जरा एग्जामिन करो. Okay, so poverty and income are another important factors, and it's been found that lower income groups which have less access to various facilities, there we have higher rates of malnutrition. Okay, and that is why in Southeast Asian, कुछ है कितना है in which will cause disability? नहीं ना, बस ठीक है. Does not cause disability. Okay. It's not of a grade which will lead to disability, so I think you can stand. Okay? कमर सीधी करके थोड़ा देर खड़े रहोगे तो ताकत आ जाएगी पैरों में, नहीं तो कमजोर रहेंगे. Okay? Then we have urban-rural difference, and you saw that difference. Okay? So rural we have higher percentages of malnutrition as compared to the urban areas. Urban we have higher percentage of overnutrition. Okay, maternal nutrition is also one of the very important factors, and also infection. And we can see that there is a spiral of malnutrition and infection which happens. So it starts with inadequate dietary intake, So the child is not adequately, breastfeeding is not adequate, then complementary feeding is not adequate. So there is an inadequate dietary intake, which further leads to weight loss. There is growth faltering, so child is not able to grow. There is lowered immunity, obviously, because the development has not been proper. And then there is a mucosal damage. Okay, so all these factors will then lead to disease incidence. The duration of the disease will increase, duration. So the child is exposed to all new pathogens after he is born, he or she is born. So all those pathogens are going to attack him. Okay. Now if the immunity is not very strong, the child will succumb to those infections, and the duration of that infection will increase. Also the child will repeatedly keep getting infected. So repeated infections ke karan the child will lose weight. Okay. So there will be appetite loss. When you are sick, do you feel like eating? You don't feel like eating, no? So child, we have some reserve. So for sickness and other periods, we have some reserve. But the child is very small, no? He does not have adequate reserve. So when he falls sick, then he will straight away lose weight, appetite loss hoga, or seedhe then there will be inadequate dietary intake. And then the spiral will keep on happening until we bring out the child from this vicious cycle. So this is a cycle which keeps on happening in any child who is not fed properly. Okay, so inadequate dietary intake will lead to infection, which will lead to increased duration of disease, which further leads to appetite loss, nutrient loss, malabsorption, and other things. And then the child again has a decreased intake. Okay. So the solution is you need to identify as early as possible the child is going into a decrease, is having a weight loss. We need to screen the child as soon as possible, जैसे weight loss में जा रहा है, because child का weight is very sensitive. Okay, when we measure it and plot it on a graph, you can actually see कि child का जो growth है वो proper नहीं हो रहा है. And in our various programs, we have growth charts where we plot their weight for age, and we can see how it is progressing. So it is said that in ICDS chart, if it's not going upwards, that means it's not, the child's का weight तो upward जाना चाहिए ना, तो graph ऐसे ऊपर जा रहा चाहिए. अगर वो stagnant हो रहा है या नीचे जा रहा है, so that means the child is losing weight. Okay, so that is like a cue कि अब इसमें action लेना है, तुरंत action लेना है. Okay. So that is how we take care of it. Then there is also maternal malnutrition, which is very important factor. Okay, and this nutrition cycle happens throughout the life cycle. So the baby is low birth weight. Okay, baby low birth weight होता है तो क्या होता है? The child is stunted. When the child becomes stunted, the adolescent also remains stunted. खड़ा करो उसको, पड़ोसी को. Stand up. Okay, so the adolescent will become stunted, and then that will lead to a pregnancy which has a low weight gain. So the child's का, you can make them stand, no issues. जिसको नींद आ रही है खुद भी खड़े हो सकते हो. You don't need to wait for me to make you stand. Okay, some self-discipline you can institute for your own self. Okay, so that cycle of malnutrition throughout the life cycle happens, and that is why in our programs, when you'll read about the programs later on in 5th semester and subsequently, so you'll realize that there is a life cycle approach that programs have. So initially the programs focused only on pregnant ladies, so we were giving supplementation to pregnant ladies so that the weight of the child increases, but it was realized that only giving supplementation to pregnant ladies was not working enough. Okay, because we had a very narrow time gap to increase their nutritional status. So then it was decided that we should increase the supplementation to the adolescent age, and then we said there should be a life cycle approach, because then adolescence comes from the childhood and then it goes back to the birth weight. So there's a whole life cycle that we need to maintain for getting the appropriate outcomes. Now maternal outcomes and infant outcomes. So maternal mortality and infant mortality or neonatal mortality are very important indicators for the health status, for determining whether the nation is healthy or not. Okay, so on a global platform, if you want to, when we want to project ourselves, these are the two indicators which the global community is going to see. Okay, and say, oh, they are not able to take care of their ladies and their kids, so this nation is not good. Okay, they have not been able to control this, and that is why all the programs are focused mainly on, there are various programs, health programs, but the focus of most of the programs is towards the health of the mother and the child. Okay, and that is the basic reason for it. Okay, so this is nutrition throughout life cycle. Similarly, underweight at birth, this is for the girl child. The girl child will eat last and least. That is in most of the households. And also she is unsupported in adolescence, and we have seen that the prevalence of malnutrition in girls is higher than that in boys in under 5-year age group, and even at later points. And then she is unsupported in adolescence, she'll be malnourished while she is into motherhood. Okay. Also, there are other practices of early marriage when the girl is not mature enough to handle the pressures of pregnancy and all, which further will lead to underweight at birth. So these are the spirals, these are the vicious cycles that are existing, and socio-cultural factors के relation में, which lead to malnourishment as a social problem rather than just a medical problem. So malnourishment cannot be just tackled by giving medicines. Okay, so if you have a malnourished child who comes to your OPD and you think that you'll just prescribe medicines and solve the whole issue, it will not be possible. So we need to identify the various factors which are behind that condition, and only then we'll be able to bring out the child from that vicious cycle. Okay, so that is the importance of telling you all these determinants and the various mechanisms behind it. Then you have lifestyle and behavioral factors, that is again the child feeding practices of mother and caregivers, and the healthcare services also. Okay, so ICDS as a program has been launched. So Integrated Child Development Services Program is a program which works. So we have Anganwadi centers at various parts of the country जहाँ पे बच्चों को supplementary nutrition दिया जाता है. Okay, so supplementary nutrition is the children come there. So 3 to 6 years age children, the younger ones are given rations for at home so that they can, their nutrition can be supplemented. But generally, even after so many years, the efficiency of ICDS has not been found to be good. Okay, and that is again because of various factors. The supplementary food that is given, which is distributed in the whole family, it is not given to the child for whom it is meant. Okay, so you give the ration, it becomes a part of the family ration. Okay, so it's not dedicatedly given to the child, and that is why the malnutrition continues. Okay, so those are the factors. Then we have biological factors, which is age, and the prevalence of underweight rapidly increases from less than 6 months, because till 6 months the child is what? Child is dependent on the mother. Okay, and there's kind of a parasite phenomena that happens. So irrespective of whether the mother is healthy or not, the child will try and derive all the nutrition out of her. Okay, so mother will be left malnourished. Even more, if she is malnourished, the child will try and extract maximum out of her. The mother will be left more malnourished, but still there will be some low weight in the child also. But then later on, when the child moves into 6 to 11 months, when the child has to be given complementary feed, खाना खिलाना शुरू करना पड़ेगा. उस टाइम में बहुत सारी प्रैक्टिसेस हैं जहाँ पे डिलेड कॉम्प्लीमेंट्री फीडिंग होती है. 1-1 साल तक बच्चों को खाना अन्नप्राशन होता ही नहीं है. So ideally it should happen at 6 months. अन्नप्राशन is a संस्कार ना, तो 6 महीने पे हो जाना चाहिए. कभी जल्दी हो जाता है, 4 महीने पे कर देते हैं. किन्हीं फैमिलीज में 3 महीने पे कर देते हैं. किन्हीं फैमिलीज में 1 साल तक नहीं करते. So it is variable and it will depend upon a muhurat or something. So it is not 6 months of age. Okay. So, and because it's a kind of, it's a celebration kind of a thing, so people might wait for people to come, so it might be delayed, and various other factors might be there. So the prevalence of malnutrition increases from 6 months, less than 6 months, to 11.9, say 37.5, and then 12 to 23 months may it increases further. So with the increasing age, the prevalence increases. Okay. बर्थ ऑर्डर में जो हायर बर्थ ऑर्डर के बच्चे होते हैं, तो पहला बच्चा जब होता है तो उसको तो फिर कुछ ख्याल रखा जाता है. ऑल्सो द मदर has a बैकअप ऑफ सम न्यूट्रिएंट्स. फिर सब्सिक्वेंटली व्हेन द बर्थ इंटरवल गेट्स narrowed and subsequent children जल्दी जल्दी हो जाते हैं, so mother does not have much reserve, and then the child obviously is not able to extract maximum out of her, and higher birth order wale they succumb to this condition. The birth intervals जितने बढ़ते चले जाएंगे उतना ही जो malnutrition का prevalence है that keeps on increasing. So 24 months का अगर gap रखा जाता है तो 52.2% है. If it's 47 months, so the percentage goes down. So 47.1%. So these are the various determinants of PEM. So it's not straightforward कि ये determinant ऐसे lead करेगा. So it is complex. So a lot of things are there. So there are political and economic structure, then poverty. Then you have other things which are basic. Then you have household food security, care for mothers and children, health, environment, and then finally you have low birth weight and poor nutrition status. So dietary intake, low birth weight, and health status will determine the nutritional status of the child. Okay, so it's complex. It's not straightforward. And that is why tackling it is also complex. Okay, so the more complex the determinants are, the more complex the treatment becomes. Okay, so now coming to the assessment. नींद चली गई हो तो बैठ सकते हो, सीधे खड़े हो जाओ. तुम नहीं बैठोगे अभी, तुम बैठ जाओ. भैया खड़ा करते हैं तो सीधे खड़ा हो जाया करो. हाँ, कमर थोड़ी देर सीधे रखोगे तुम्हारे लिए बेनिफिशियल है. Okay, so assessment and classification of PEM in the field, because it's a disease which you'll not find in hospitals. It's a condition that you'll not find everyone coming to hospital. So it's a condition which remains, that iceberg phenomena, if you remember, tip में बहुत कम मिलेंगे. So all majority of it will be submerged. Okay, only when the child is all kind of almost moribund, तब वो लेके आते हैं कि अरे बच्चे को मतलब ये नहीं हो रहा है. बीमारी के लिए लेके आते हैं तो चाइल्ड का इन्फेक्शन और अंडर न्यूट्रिशन दोनों साथ चलेगा. बीमारी के लिए लेके आते हैं, लेकिन इफ यू आर नॉट observant enough to identify the loss of weight or weight loss that the child is also having, you might miss the malnutrition while you are treating infection. So इसीलिए pediatric जो भी consultations होती हैं उसमें it is mandatory to get the weight of the child for two reasons. One, because you have to prescribe medicines according to their weight, and another important reason which is there is you need to screen them for any protein energy malnutrition, because it is very common. 50% के around है prevalence. तो अगर इतना common है तो हमें सबको screen करना चाहिए. Okay, 50% अगर हम कह रहे हैं तो that means almost हर दूसरा बच्चा हमें मिल जाएगा. अगर 30% हम मान रहे हैं तो हर तीसरा बच्चा मिल जाएगा. ओके, और जो हमारे पास आ रहे हैं बच्चे अगर, तो वो तो उनमें तो और प्रेवलेंस ज्यादा होगा. ये तो कॉमन पीपल के बारे में बात है. तो हॉस्पिटल में जो आ रहा है तो उसमें तो और रेट्स ज्यादा होंगे. सो वी हैव टू स्क्रीन एवरीवन फॉर malnutrition. That is important, and these are various techniques which are there for assessing malnutrition, PEM. So it's a spectrum of conditions, and there are various classifications which are given. Okay, so we'll discuss each of the classifications. So there are various cutoffs which are used. So IEP classification is commonly used in the ICD's growth chart which is there. So we have the IEP classification there, and we have a WHO classification also for others. So mid-upper arm circumference is one method which is used, and it is very commonly used. This is done very easily. कुछ करना नहीं है, एक टेप होता है. Okay, it's a non-stretchable tape method, which measures the circumference midway between the acromion and the olecranon. So you mark the olecranon and the acromion process, और उसके बीच में length measure करके half में mark कर दिया जाता है. Normal for children between 4 months to 4 years of age is 13.5 to 16 centimeters. Okay? So 4 महीने से लेके 4 साल तक के बच्चे, यानी 5 साल से पहले वाला बच्चा, 4 साल का बच्चा होता है, 4 साल 11 महीने 29 days is also 4 years only. Okay? Until this the child is 5 years. So less than 5 years में it remains kind of, no, it does not increase, the girth does not increase much, and it is 13.5 to between 16 centimeter होना चाहिए for a normal child. So this is Shaki tape which is there, and if it is greater than so if it is greater than 13.5, it is normal. If it is between 12.5 to 13.5, it is borderline, so it is the child is at risk. And if it is less than 12.5, then the child is wasted. It's gone into malnutrition. Okay. If it is less than 11.5, it's gone into severe acute malnutrition. Okay, which is SAM. Then another thing that we have is chest circumference and head circumference. This is done. If we say that at 1 year of age, it is 1 at 1 year of age. The ratio is 1 at 1 year of age. And if it is less than 1, it signifies malnutrition. Okay. So 1 year of age में दोनों का ratio same रहता है. So if the chest circumference does not grow, okay, and the head circumference is obviously, if the child is malnourished, the chest circumference will not increase. And if it's not increasing, the ratio is going to be less than 1. Okay. So अगर less than 1 हो रहा है, so that means the child is getting malnourished. खड़े हो जाओ. हाँ, पता है तुम्हें कि नींद आ रही है. मेरा simple punishment है. See what I can do. I mean, I have to teach you also and punish you also. Both things I have to do. So this is a simple punishment that I have, found during all my years of teaching, and this has been found to be effective. Okay, when you stand, you have a better concentration. Better tha na? Or you were lost? Tell your experience. Slightly better, no? I know. It was slightly better than when you were sitting, na? Yeah. Isn't it? Yes. And even after you have sat down for some period of time, it still persists, no? That attention is still there, no? थोड़ी देर बाद फिर से वापस वैसे ही हो जाता है, लेकिन at least for that period of time, you can make the most of it. So Gomez classification is weight for age classification, in which weight of the child is taken and it's compared with the weight of a normal child of same age, which are standards which are there. And we have these classifications. So normal is between 90 to 110%. First degree is 75 to 89%. Second is 60 to 74%. And third degree is less than 60%. Okay, so that is the Gomez classification. And it is easy to use because weight is very easy to measure. Okay, weight को measure करना बहुत मुश्किल काम नहीं. Height measurement में थोड़ा सा technicality होती है कि height exactly हम कैसे measure करें ताकि errors ना हो. Weight में there are less of errors. कि बच्चे को उठा के डाल दिया, उसमें जीरो का सेट देख लिया और उसका लटका दिया, या सॉल्टर्स जो स्प्रिंग बैलेंस है उस पर लटका दिया, वेट निकल के आ जाता है, मेजर कर लिया. When you measure the length or the height of the child, that is a slightly tricky method because छोटे बच्चों में उनके पैर मुड़े हुए होते हैं, knees are not straight and all. तो वहाँ थोड़ा सा technicality होती है. Okay? Disadvantages क्या है? The cut point is of 90% for the normal. 90% is the cut off, no? 90% का cut off थोड़ा सा high है. Okay? So high cut off होने से क्या है कि कुछ normal बच्चों को भी हमने grade 1 में डाल देंगे. Okay? So we'll kind of overestimate this. Only weight is measured, so it is difficult to know that if low weight is due to an acute malnutrition or is it because of long standing. ठीक है? अगर long standing है तो क्या जाएगा? Long standing malnutrition है तो क्या मिलना चाहिए? अगर किसी को long standing malnutrition है तो क्या मिलेगा तुम्हें बच्चे में? Yes. वेट इफेक्ट होगा, हाइट इफेक्ट होगी, दोनों होगी ना. सो हाइट ऑल्सो विल बी अफेक्टेड. इसमें सिंस इट इज जस्ट वेट, सो वी डोंट नो वेदर दिस वेट लॉस वाज बिकॉज ऑफ एन एक्यूट malnutrition or because it was of a chronic malnutrition. Okay? पीछे, third row, fourth row in fact, 1 2 3 fourth row, third child. इधर उधर देखते क्या हो, तुम्हें खुद ही पता होता है कि हाँ मैं ही हूँ, खड़े हो जाया करो. इधर उधर देख रहे थे, कोई और भी सो रहा था क्या, मैं बचा कि नहीं बचा? हाँ. Okay, so only weight is measured, so it is difficult to classify it. Then Boston standard used in above classification is no longer an international reference data, so it's not used. Then we have a Waterlow's classification, which classifies both the child as both normal, wasted, stunted, and wasted and stunted both. Okay, so we see the weight for height also of the child and height for age also of the child. So अगर height for age less है than the mean -2 standard deviation से अगर कम है तो child क्या होगा, stunted होगा या wasted and stunted होगा. अगर height कम है उसकी, सिर्फ height कम है, weight कम नहीं है तो stunted हो गया. अगर height भी कम है और weight भी कम है, दोनों कम है, तो wasted और stunted दोनों हो जाएगा. ओके, whereas अगर दोनों ठीक है तो normal होगा, सिर्फ अगर weight कम है तो wasted हो जाएगा. Okay, so this is how we classify according to Waterlow's classification. So we see both the weight of the child also and weight of the normal child of same height. So weight for height देखते हैं, and we see the height for age, of the child divided by height of a normal child of same age. Okay, and then we interpret the indicators as normal. So stunting when it is more than 95%, okay, that's normal. Okay, and if it is mildly impaired, we'll say that height for age is mildly impaired if it is 87.5 to 95. Here it is wasting if it is 80 to 90, and these are the cutoffs which are there. So severely impaired will be, less than 80 and less than 70. Okay, so that is the cutoff for Waterlow's classification. Then we have a WHO classification also, which is based on NCH's data. And we have weight below median -2 standard deviation. So we don't use means, we use median -2 standard deviation because it is a variable indicator. I mean variable ऐसा constant नहीं है. Averages नहीं मिलते ना. Normal population में जब हम देखते हैं तो काफी variation दिखता है. उस variation को account करने के लिए we take medians rather than mean. Okay. So median -2 standard deviation अगर below है तो moderate. And -3 standard deviation के अगर below है तो we say it is severe malnutrition. Okay, so median that is used is NCH's reference populations method. SAM क्या होता है? SAM is very low weight for age. So below 3 standard deviation if it is there, Z scores for median as per WHO growth standards, we classify it as severe acute malnutrition, which is SAM. Okay. Visible severe wasting होती है, bipedal edema होता है बच्चे को, and mid upper arm circumference is less than 11.5. Okay, so these are present in a child who has SAM. So any one of it is, if it is there, we classify the child as SAM. Moderate acute malnutrition is defined if weight of height is between 3 and 2 standard deviation as per median, and there is less severe wasting. MUAC जो है 11.5 to 12.5 के बीच में है. And अगर कोई भी edema है बच्चे में तो उसको हम SAM classify करेंगे. Okay, so अगर if the child has edema, that means the child has gone into SAM. Then this is the IAP classification. Again weight for age के ऊपर base है, which is the cutoffs are different. So Gomez में it was 90%. Okay, whereas here it is slightly relaxed. So 80% is normal. अगर 80% के ऊपर है तो normal. Then we have 70 to 80 as grade 1, 60 to 70 as grade 2, grade 3 and grade 4. Okay. So depending upon the grades of malnutrition, the management changes. Okay. So grade 1 probably it will be home based management, grade 2 will be an OPD based management, grade 3 and 4 you will refer to a center, tertiary care center for this. Then there is a Wellcome's classification also, where we classify as Kwashiorkor, Marasmic Kwashiorkor or Marasmus. So these are the grades for Wellcome's classification, where we see weight for age and edema simultaneously. Okay. Okay. Then basically there are two main conditions which are found. So Marasmus and Kwashiorkor. So these are the two protein energy malnutrition conditions or classifications which are clinically visible. So marasmus is characterized by gross wasting. So this is a marasmic child. So there will be gross wasting of muscle and subcutaneous tissue, which results in emaciation, marked stunting, and no edema. Whereas in a child who has Kwashiorkor, you see a pot belly, abdomen, and a moon facies, and you can see the edema on the legs. Okay, so the child in दोनों malnourished है, लेकिन Kwashiorkor में it is more edematous appearance. In marasmus it is more emaciated appearance, which is evident. Okay, so it's grossly underweight, no body fat, gross muscle wasting, old man's facies होता है, no edema, normal hair. And here we have edema, will not eat the skin. ये इसका voracious appetite होता है marasmus वाले बच्चे का, बहुत भूख लगती है उसको, खाता है. Kwashiorkor का बच्चा उसको भूख चली जाती है, वो खाता नहीं है. And there are typical signs and symptoms. Skin patches होगा, hair pale, thinned होगा. So we'll just see it in a tabular format. Clinical features, they are always present in both the conditions. Muscle wasting is obvious in marasmus. Kwashiorkor में it is sometimes hidden by fat, edema and fat. Edema से छुप जाएगा, दिखेगा नहीं, but it's there. Fat wasting, severe loss of subcutaneous fat happens in marasmus. In Kwashiorkor, fat is often retained, but it is not firm. Okay, so that firmness goes. Edema is not there in marasmus. We'll have it in Kwashiorkor. Weight for height is very low in marasmus. Kwashiorkor it is low, but it is masked by edema. So weight for height therefore does not help much, and that is why any edema we classify it as SAM. Because जब आप अगर किसी बच्चे को edema है और उसका weight for height लोगे या weight for age लोगे, तो you will not get a correct interpretation. क्योंकि वो weight water के कारण है या weight उसका actual weight है, we cannot differentiate. So that is why weight for height is actually, or weight for age is not taken for a child with Kwashiorkor. And if the child has edema, that means straight away the child has this, okay, PM. Mental changes, sometimes quiet and apathetic होता है बच्चा. Kwashiorkor में irritable होता है, moaning होता है, and apathetic होता है. Okay. Then you have other features, that is clinical features which are sometimes present. So appetite in marasmic child is usually good. Kwashiorkor में poor होगी. Skin changes, marasmic child does not have. In Kwashiorkor there is diffuse pigmentation and flaky paint dermatosis. जैसे flaky paint appearance होता है ना, जब paint उतर रहा होता है. देखा है कभी paint कहीं paint होता है, उसमें से जब पेंट उतर रहा होता है गीलेपन की वजह से या मॉइस्चर की वजह से, तो वो जो उतरता है तो जैसा अपीयरेंस होता है वैसा अपीयरेंस स्किन का हो जाता है in a Kwashiorkor child. Because of the edema, long standing edema and changes that have happened in the skin, there's a flaky paint dermatosis which happens. Hair changes are not found in marasmus, whereas in Kwashiorkor you'll find a sparse, silky, easily pulled out hair, तो बहुत easily टूट जाएंगे. Okay, so pluckable, easily pluckable hairs होते हैं. Also there is a flag sign which is there. Flag sign मतलब बच्चा जब normal growth होता है तब तो उसकी dark pigmentation होगी, फिर उसके बाद जब abnormal growth होगा तो उसकी pigmentation low हो जाएगी, फिर normal होगा तो फिर dark होगी. तो बच्चे बहुत आप commonly देखो जो lower socio-economic status के बच्चे हैं, उनके बाल जो होते हैं, they are not of the same color as you and I have. Isn't it? Have you noticed that? They have a अजीब सा shaded सा color appearance होता है. Meditation में चले जाते हैं बच्चे. So you should wish कि कोई और सोए ताकि जब वो सोएगा उसको उठाएंगे फिर तुम्हें बिठाएंगे. हाँ, ऐसे ही कर रहे हैं ना? So we are playing this musical chair. Okay? Okay, so there is a flag sign which appears. Okay, then there is hepatic enlargement in Kwashiorkor due to accumulation of fat, and marasmus it is not seen. Biochemical features में serum albumin is normal or slightly decreased in marasmus. Kwashiorkor में it is pretty low, less than 3 gram per 100 ml, and plasma amino acid ratio is normal in marasmus, and Kwashiorkor it is elevated. So those are the basic differences between the two conditions. Clinically, when you see them, you can differentiate very easily because of the edema. So you don't need much clinical this acumen to decide whether the child is having marasmus or a Kwashiorkor. Okay. Complications, because it is accompanied by other things also, mineral imbalance, vitamin imbalance, electrolyte, water imbalance, diarrhea hota hai. Diarrhea is a very common condition which leads to diarrhea and respiratory infections. These are the two conditions which are most common in child. Okay, most common infections in child, and because of these two infections, the child will keep on having repeated episodes and PM. So water electrolyte imbalance hota hai, hypothermia, hypoglycemia, and other infections and other deficiencies happen. So these are all the complications of protein energy malnutrition that are documented and that are seen. Preventive measures, we need to do health promotion. So health promotion will focus on what? Health promotion will focus on the determinants. Prevention is directly associated, or you can link prevention methods with the determinants. So once you know the determinants clearly, if you remember the determinants, you will be able to find out the... मैं अभी तो खड़ा किया था ना, फिर सोने लग गए. खड़े हो जाओ फिर से. खड़े हो. हाँ, कोई बात नहीं, ऐसे ही खड़े हो जाओ. अभी तो खड़ा गया था, फिर सो गया. नहीं, उसका रिपीट वाला है ना, सो तुम्हें नहीं रिलैक्सेशन है. जो नया होगा ना तो फिर होगा. ओके, सो इट इज डिटर्मिनेंट्स जो होंगे उससे ही एसोसिएटेड तुम्हारा प्रिवेंटिव मेजर्स होंगे. सो हेल्थ प्रमोशन will include measures directed to pregnant and lactating women. Okay, education, supplements, promotion of breastfeeding, low-cost feeding food, family planning to reduce the size of the family क्योंकि higher birth order में ज़्यादा होता है. Birth interval increase करना, home economics maintain करना so that you can. Okay, so the girls are also sleeping, so we can have second last में third girl. Second last row में इस side से third. Generally, rate of sleeping in girls is less as compared to boys. I mean, that has been my observation. That has been a common observation. Girls are more attentive. Boys are overworked. रात भर उनको मूवी देखनी होती है, पता नहीं क्या क्या उन्हें करना होता है. Girls are more disciplined. Okay. So family environment in सब पे focus होगा. Then you have specific protection measures. Silence, please. Specific protection measures, that means we give a specific thing for improving the nutrition status. So protein energy rich food is provided to children so that they can improve their status. Immunization is very important because immunization अगर proper है तो कम से कम common जो 6-7 diseases हैं वो बच्चों में नहीं होंगी. And उनके infection से the child will be saved. Food fortification is another method that can be used for specific protection. Then early diagnosis and treatment, very important because as I told you, weight for age is very sensitive indicator. बच्चे का weight बहुत जल्दी गिरता है क्योंकि उसके पास कोई reserve नहीं है. तो जो खा रहा है वही यूज कर रहा है, कोई उसके पास body reserve नहीं है. तो अगर infection है या उसकी appetite थोड़ी भी कम हुई है तो उसके weight में तुरंत significant decline आएगा. So screening the child for weight for age is a very important tool that we have to find whether the child is going into malnutrition or not. Okay, so that is the key to identify PEM. Okay, as early as possible. क्योंकि जितना late हो जाएगा उतना भाई साहब बिल्कुल ही सो गए, बिल्कुल कोने वाले हैं. खड़ा कर दो इनको. दोनों, अच्छा 2 थे. हाँ देख एक ही रहा था. आ जाओ बेटा, इधर आ जाओ. स्टैंड अप, स्टैंड अप, स्टैंड अप क्विकली. इधर बाहर आके खड़े हो जाओ बेटा, बाहर आके. हाँ आप भी. Okay, so early diagnosis and treatment will include this and identification as early as possible. So silence please. Then you have rehabilitation. which includes hospital treatment and at nutrition rehabilitation centers and follow-up care. Okay. Then we have investigations, which will include all investigations of the silence, please. Investigations will include the complete investigations for any associated infections and other profile. Okay, so full blood count, glucose, septic screening, etc. Okay. Also for PEM, since we have creatinine ratios and all are disturbed, so AG ratios are disturbed, so we have to enough please. बेटा अब सिर उठा के खड़े हो तो स्लाइड भी देखनी है. खड़ा करने का मतलब पनिशमेंट सिर्फ नहीं है, खड़ा करके पढ़ाना है. ओके, सिर्फ खड़ा नहीं करना है. तो पनिशमेंट नहीं दे रही हूँ, आई एम मेकिंग यू लिसन टू द लेक्चर. दैट इज द पनिशमेंट. Complications, we have these complications which can happen in a child. So hypoglycemia, hypothermia, silence please. Hypothermia is a very common complication that happens and the child succumbs to hypothermia very quickly, especially in the initial 28 days of life. 28 days of life में hypothermia के कारण और hypoglycemia के कारण death in children is very common. जैसे infection होता है बच्चे को, वैसे ही वो hypoglycemia और hypothermia में जाता है and the child succumbs to it. Okay, kangaroo mother care is one method by which hypothermia is prevented. Okay, so that is a very unique method and very useful method without any use of resources, which can be done at home by the patient to prevent hypothermia. Okay, those methods of KMC and all will be teaching you later on. Okay, so these are complications. The principles will include prevention of hypoglycemia or treatment. So initial days में first 2 days hypothermia, dehydration, imbalance of electrolytes throughout 2 to 6 weeks तक, जब तक हम पूरा चाहते हैं. Micronutrient deficiencies का correction, infections का treatment till day 7. So all this is included for the treatment of the child along with follow-up and loving care and play. So it is a comprehensive management that happens. It is not one day management that happens कि आज आपने treatment लिखा और ठीक हो जाएगा बच्चा. It spans over a period. Please, why is there so much of talking going on? तुम्हारे पीछे कौन बैठा है? Please remove the bags. Yeah, I'm just completing it. Please let me complete it. Okay, so these are the 3 phases of treatment: stabilization, transition and rehabilitative phase, and the various formulas which are there for feeding when you try to rehabilitate. Like एग्जाम में सिर्फ उतना ही नहीं पूछा जाएगा जितना तुम्हारा क्लास में हो गया. ओके, एग्जाम में आगे का भी पूछा जाएगा ना. So let me finish it so that at least you are aware of what you have to read. Okay, so please stay with me for 2-4 minutes. Okay, the prognosis, there is a greater risk of morbidity and mortality. We know that. Early detection and adequate treatment are associated with good outcomes. So as early as possible, we have to identify it and treat it. And late ill effects, the children who are malnourished in their childhood, they tend to have a lower IQ. There are behavioral problems, there are cognitive function impairment, and other things which are doubtful and not proven as a direct link, but it is observed. Okay, so that is all about protein energy malnutrition, and next we'll discuss about the assessment of nutrition status. Roll number 1 to 10, stand up.
Roller 1 to 10.